Hello everybody, this is the 2022 Advanced Exam Gaps in Knowledge Report presentation. We'll go over all of the topics that were written by the ABA this year that ended up on the Gaps in Knowledge Report. Every year after the advanced and the basic exams are given, the ABA produces a report called Gaps in Knowledge, which is essentially topics where the vast majority of test takers got them completely wrong. What the ABA does when one topic is severely misunderstood is they go back and find all of the relevant research that the question was written on, and they verify that the correct answer that they said was correct is actually correct. Once they do this, they put the topic on the Gap in Knowledge report. They send it out to all the program directors like me, and they expect that I communicate this information to you so that the next time you see this topic on a test, you can get it right. So that's what we'll go through today. The first topic is continuous wave Doppler versus pulsed wave Doppler. Ultrasound has become one of the tools that the ABA really expects us to know about, not only how to use it and in which different situations, but ultrasound physics as well, and what these different terms mean and how we can use them. So what continuous wave Doppler is ultrasound that is emitted continuously and analyzed continuously. There are some benefits and some drawbacks to this type of Doppler. So a benefit is that faster velocities can be picked up because it's not limited by something called pulse repetition frequency, which describes the amount of time that the ultrasound needs to pause to analyze. Since it analyzes and emits continuously, it can analyze very, very fast velocities. Now, a disadvantage of that is that since the ultrasound probe is sending out ultrasound continuously along a straight line, it's impossible to know where the fastest velocity is occurring. Generally we can assume that this is in a stenotic area, but that's not always the case based on the imaging. So the one disadvantage, as I said, is that you can't tell where along the ultrasound path the fastest velocity is occurring. Now contrast this to pulsed wave Doppler, where the ultrasound probe sends out a signal, waits, receives the signal, and then analyzes that signal. As I mentioned, it's limited by pulse repetition frequency, and by definition that's the amount of time that the probe needs to analyze the signal. Now the advantage is that you can know where exactly along the path of the ultrasound you're measuring. But the downside, again, is that very, very fast velocities can be missed. When these fast velocities are missed, there's an effect called aliasing that alters the signal and ultimately the image pretty dramatically. If this confuses you, please ask the cardiac people to explain this to you again. They do a really good job of making this seem a lot more simple probably than I did. The next knowledge gap is ECG findings during ischemia. Now, as you all know, when the heart experiences ischemia, there are EKG changes that can occur depending on the distribution of the coronary arteries that are experiencing ischemia. So this image over here on the right can illustrate that a little bit. So with anterior ischemia, when the LAD is the affected vessel, we can see changes in the precordial leads and lead 1 and AVL. When the heart experiences inferior ischemia, which can be the RCA and right dominant folks, and the circumflex and left dominant folks, changes can be seen in leads 2, 3, AVF, and then we can see reciprocal changes on the lateral leads. This image over here, can illustrate this even better by studying a little bit further for, where ischemia occurs and the leads that you see changes in. Our next gap is coagulation factors in pregnancy and the changes in these factors during pregnancy. They reference specifically factor 8 as being a factor that a lot of folks were confused on. But in general, pregnancy is a hypercoagulable state. Many of the clotting factors are increased during pregnancy. And this includes factor 8. So 1, 7, 8, 9, 10, 12 all see increases. The anticoagulants, protein C and S, either decrease or there's an acquired resistance, which is the case with protein C. There are some other hematologic changes as well. Both platelet production and consumption increase, and this leads to thrombocytopenia, which for those of you who have been on the OB floor have certainly seen. Plasma volume tends to increase, but it increases more than red blood cell volume increases, and so this leads to anemia even though the overall blood volume is increased. Our next topic is on end-stage liver disease and hyperdynamic circulation. So we know that as the liver fails, different mediators cause vasodilation. This systemically decreases SVR, and as a compensatory mechanism, cardiac output is increased and heart rate is increased. Now there are two other phenomena that can result related to the lungs in end-stage liver disease. These are portopulmonary hypertension and hepatopulmonary syndrome. Now, portopulmonary hypertension is a pulmonary hypertension disease in liver disease. It is due to mediators that ultimately cause smooth muscle proliferation and hypertrophy of the pulmonary vasculature. In this, thrombosis can also occur, and this can ultimately lead to right heart failure. Now contrast this with hepatopulmonary syndrome, which is a different sort of lung disease in liver failure. The definition of hepatopulmonary syndrome is the triad of portal, not pulmonary hypertension, arterial hypoxemia, and pulmonary vascular dilation. Since pulmonary vessels become dilated in this disease, shunts are created, which leads to hypoxemia. These two can be differentiated, and this was the point of the question that was missed by many. These two can be differentiated by different hemodynamic variables. So by measuring PA pressures, cardiac output, pulmonary vascular resistance, and others, we can differentiate the pulmonary hypertension disease, which is portopulmonary hypertension, from a shunting disease, which is hepatopulmonary syndrome. Our next topic is acute fatty liver of pregnancy. So acute fatty liver of pregnancy is a relatively rare disease in pregnancy that occurs during the later part that has an extremely high maternal and fetal mortality rate of about 20%. What this is microvascular fatty infiltration of the hepatocytes themselves, and the liver does not become necrotic. It does not become inflamed. It simply takes on fatty deposits within the hepatocytes themselves. Now, there are some unique characteristics of this disease that differentiate this disease from other common liver diseases that we see, such as cholestasis, various viral hepatitises, HELP syndrome, and I've listed them below. They, without reading down the list exactly, we can see from the figure that, with any liver disease, there can be encephalopathy. The patients tend to be jaundiced because, bilirubin is breakdown is affected in this disease. Patients tend to become hypoglycemic because the liver failure tends to interfere with production of glucose. and there are different decreases in synthetic hepatic function, which we don't often see in the other liver diseases of pregnancy. There are also other sort of more vague symptoms such as anorexia and vague epigastric pain. Diagnosis of acute fatty liver pregnancy early is incredibly important to limit the mortality for both the mother and the baby. Our next topic is X-ray scatter and how this affects us in the operating room when working with radiation. So when X-rays are used, the primary source of radiation is the bottom portion of the C-arm, when the C-arm is what is being used. This is often confused with the receiver. Many folks believe that the receiver is the source of radiation, but this actually isn't true. It's the bottom portion of the C-arm. Because the radiation is emitted from this source in a directed sort of way toward the patient, we often are not exposed to radiation directly from this source. The majority of the radiation that we see, and the reason that everyone wears lead in the operating room, is from scatter. What scatter is radiation that is emitted from the source and then hits an object, whether that object is the patient or the table or any other equipment between it and the receiver. And then that radiation is thrown all over the place in various directions. Since the radiation beam is directed at the patient, the highest portion of scatter comes from the patient itself. So the question that many folks got wrong is that the closer the anesthesiologist is to the patient, the higher rate of exposure to radiation the anesthesiologist sees. As I've told many of you before, radiation decreases in squares. So if we're standing 1 foot away from the patient and then move to 2 feet away from the patient, we've decreased our radiation exposure by a factor of 4. Our next topic here is the retrobulbar versus peribulbar block. Now, many of you probably have never done either a retrobulbar or a peribulbar block, and if you have, it must be because you were in the presence of a very patient and kind ophthalmologist who was interested in teaching. But most anesthesiologists, definitely in our practice and in many practices, don't do these blocks routinely. So there are a few key differences between them, and they do appear, both of these blocks do appear on retina exams quite a bit. So a retrobulbar block, as you can see from the image, places local anesthetic behind the globe. One of the downsides of this block is that it does not produce complete akinesia of the eyelid, which means that the eyelid can still move, but does provide fairly good anesthesia to the entire globe and to all the extraocular muscles as well. Now, there tend to be more complications with a retrobulbar block as opposed to a peribulbar block. Since the needle is being placed behind the globe, you can be at risk for retrobulbar hemorrhage. You're more likely to perforate the globe because you're placing the needle much closer to the globe itself. You can get inadvertent central spread of local. That's done by depositing the local far too close to the optic nerve, and you can actually get a high spinal from performing this block. You can also put yourself at risk for the oculocardiac reflex because the deposition of the local in that area, pushes on the vagus nerve, the trigeminal nerve, which kicks off the oculocardiac reflex. Most of the time here, peribulbar blocks are done. More local has to be given to have the same effect. But one benefit of this is that you do get akinesia of both all extraocular muscles and the eyelid because the local tends to seep into the eyelid from the location that it's injected in, as you can see on the picture. There tend to be fewer complications with peribulbar blocks. You can get periorbital ecchymosis and sometimes spread to the contralateral eye just because of the increased volume of local that is needed, but in general it tends to be a safer block to do than the retrobulbar. Our next topic goes into the various branches of the intercostal nerves. Anatomy is still a fairly widely tested topic on the advanced exam, not just the basic exam, and they tend to get pretty detailed when it comes to the anatomy questions. So this goes into the intercostal nerves and the branches. There are three main branches with each intercostal nerve. There are the muscular branches, the cutaneous branches, and the communicating branches. Now, the topic in question was about the cutaneous branches and the fact that the lateral cutaneous branch supplies the largest portion of skin on the chest. The anterior cutaneous branches supply the medial and lateral portion, but the much larger anterior and posterior chest are supplied by the lateral cutaneous branches of the intercostal nerves. Very picky, but this was on the test. Muscular branches, of course, supply motor innervation, whereas the cutaneous branches supply sensory innervation. And then the communicating branches link the sympathetic chain to the intercostal nerves. These have sympathetic fibers that run up and down. This gap in knowledge was regarding tourniquet sizing and limb surgery. Now, oftentimes we don't necessarily decide on the tourniquet that the surgeons use during different surgeries, but it is important to understand that a tourniquet is being used and how to avoid some of the complications of the tourniquet itself. So the topic of this question was that the width of the tourniquet should be at least wider than half of the limb's diameter. So the width of the tourniquet should be at least as wide as half of the limb's diameter. And what this means is that the wider the cuff is, the less risk of injury there is to the limb. And ultimately, if you cover more surface area, you're not required to use as much pressure in the tourniquet to occlude the vessel. Now, I don't believe the question went into this, but also length of the tourniquet is important. So the tourniquet should overlap by at least 3 inches, but not more than 6. And what folks have found is that the short cuffs can either pop off or incompletely compress the vessels. So larger, greater pressures have to be used with shorter cuffs to occlude the vessels. And longer cuffs can cause inadvertent higher pressure and can also damage skin underneath by wrinkling it and pinching it. And when those tourniquets are blown up to very high pressures, it's very easy to lead to different injury. So this topic went into the various causes of mortality related to transfusion. And the point that they wanted to drive home was that TACO, transfusion-related overload, is the most common cause of transfusion-related mortality now. So the two most common are trolley and TACO. We're forever differentiating these two types of transfusion complications. TACO, as I said, stands for transfusion-associated circulatory overload. The idea behind TACO is that a two-hit model is employed. So first you have an injury that results in either cardiac or renal impairment, and then with massive transfusion, you get volume overload, so the heart and kidneys are unable to handle this extra volume. In 2017, a paper was done with the citation below there that outlined that 60 out of 136 reported transfusion-related deaths in 7 years, starting in 2010, was in fact related to TACO. Now, TRALI is a little bit different. It's pulmonary edema that occurs when no fluid overload exists. The hypothesis behind TRALI is that anti-leukocyte antibodies are transferred through the transfusion, and this recruits essentially white blood cells to the lungs, which cause this pulmonary edema. This was previously thought to be the highest cause of mortality, but more recent studies have shown that TACO is more likely a cause of death than TRALI. This Venn diagram over here sort of shows other ways to differentiate TRALI and TACO, and it's worthwhile to go through this. So anticoagulants and neuraxial anesthesia will go hand in hand and battle each other for all of time. So questions come up on the exam all the time, and I think that this one was probably missed quite a bit by folks just because the question targeted a route of anticoagulation that we don't usually see. So this was about unfractionated heparin given subcutaneously as a therapeutic anticoagulant. Now, we give Lovenox frequently in a therapeutic dose. We give many of the other newer anticoagulants in a therapeutic dose, although heparin given sub-Q is often not given in this way. So the table I created here outlines the amount of time that you have to hold heparin before you attempt neuraxial anesthesia. So what we see commonly is IV heparin, IV therapeutic heparin, which after it's turned off, we need to wait at least 4 to 6 hours. We oftentimes will see subcutaneous low-dose prophylactic sub-Q heparin. After this is given, we need to wait 4 to 6 hours or have an assessment of coagulation status. Sometimes we will see also high-dose prophylactic sub-Q heparin. That can be 10,000 BID or TID dosing. When this is employed, we need to wait 12 hours and have an assessment of coagulation status. The route in question here was subcutaneous therapeutic heparin. Now, the recommendations through ASRA are that we wait 24 hours and have an assessment of coagulation status. So I'm sure that this threw folks off just because of the route and fact that we were looking for therapeutic heparin. Now, our next topic looks at the relationship between diabetic neuropathy and thermoregulation. So many people with diabetic neuropathy will have delayed vascular constriction when they become cold and delayed dilation when they become warm, which throws off their thermoregulation. Now, under anesthesia, the inability to constrict blood vessels quickly leads to increased loss of heat from the core into the periphery. Now, the graph on the right shows normal patterns of heat loss after induction of either general anesthesia, which is the black line, or after a neuraxial block, which is the red line. Now, the blue line mimics what heat loss looks like in someone who has diabetic neuropathy, because this plateau phase, which is beyond the third hour there on the x-axis, is never reached. Our next topic here is nerve supply to the testicles, and I said in the last anatomy question about the intercostal nerves that they tend to get extremely picky about anatomy with these questions, and this certainly is no different here. So the nerve supply to the testes, not the scrotum, is from the T10 nerve root. This is because if you go all the way back to embryology in medical school, the testes are derived in a similar area as the kidneys are derived, which are higher up into the thoracic dermatomes. The nerve supply to the scrotum arises from nerves of the lumbar plexus. These are the ilioinguinal nerves and the iliohypogastric nerves. But innervation to the testes themselves comes from the thoracic nerve roots. This next knowledge gap was surrounding the ASA guidelines for delivery of office-based anesthesia. So the ASA has put out a guideline that describes what is necessary to perform certain procedures in a non-hospital-based setting. This document includes defining different medical leadership roles within that facility. It talks about compliance with the standards of the building itself. It goes into the different procedures that are able to be done in an office-based setting, and that the procedures should be appropriate for the setting, and the patients must be able to be discharged from the facility when the procedure is over. The patients going through procedures in offices must have the same pre-op assessment that is done in a hospital setting, the same intraoperative monitoring that's done, and also meet the same post-op discharge criteria as in a hospital. The facility must also have access to oxygen, suction, resuscitation equipment, and emergency drugs that are necessary in case of emergency. And the staff in these offices must have appropriate training to just in case there's an emergency and ultimately the patient needs to be transferred out. I believe this question was particularly pertaining to the fact that oxygen delivery must be monitored as one of the bits of criteria for giving anesthesia in an office. This next knowledge gap discussed how elderly patients in particular can be at risk for accumulation of local during blocks and are more at risk for local anesthetic toxicity. So the thinking here is that in general, the elderly population has a decreased amount of muscle mass when compared to younger patients. Since muscle can act as a reservoir for local, since there is less muscle mass in an elderly population, it's more likely that the drug will be absorbed systemically and cause toxicity. Also, multiple comorbidities can reduce the body's ability to clear out local, putting patients at higher risk for local toxicity, and also reduced perfusion of organs that clear the local will ultimately lead to an increased accumulation. So for these reasons, they say that elderly folks are more at risk for local toxicity, and a question was asked to that effect. Our last gap is in the realm of MRI. The board loves to sneak in an MRI question or two every once in a while, and this year they decided to test the magnetohydrodynamic effect. What this is an interference that is seen on EKG in its simplest terms. Next time you're down an MRI, you can take note of how different the EKG looks, and it is due to this effect. As blood flows through the body, and therefore through the magnetic field of the MRI, small voltages are created that can interfere with the EKG signal. In particular, the amplitude of the T wave can be increased and alter the overall morphology of the EKG. As you can see from this image, as the strength of the MRI magnet increases, this effect is more pronounced. All right, thank you very much for watching. I hope you guys take something away from this, and if similar questions show up this year on the advanced exam, I hope you guys do well. All right, thank you very much. Take care.